Welcome to the discussion of the UWORLD Question ID 4127. The case presented is of a male patient, 75 years old, having chest pain since 6 months ago. It's substernal with exertion. So these things are typical of angina, stable angina, chronic stable angina. It's not acute, it's already there for 6 months, so this is stable angina. Risk factors include hyperlipidemia and smoking, as mentioned in the case, and the physical examination is normal. So this would exclude or might exclude other causes of chest pain, like if there is a pneumonia, pleural effusion, it would be dull to percussion. If there is tenderness, this would be costochondritis. So take care of these notes. So we do a stress testing for a case of chronic stable angina. This is the best initial test we do for any patient with chronic stable angina. Normal resting ECG is really important to have. It's really important to understand this. If there is an abnormality in the basal ECG, like the ECG we do at the bedside while resting, then we might not be able to read if abnormality appeared after the stress testing. So we have to initially do this ECG to know. If it's normal, then we can proceed into doing the stress testing, like to induce ischemia in the heart by exercising or by other chemical ways. And here we are just doing normal exercising. The basis of stress testing is that you can read the ECG. What we mean is you can read ECG normally, like there's no abnormality in the basal ECG or the baseline ECG, let's call it. So this is the first thing. The second thing, he can exercise. The patient can exercise. If he cannot exercise due to arthritis or due to amputation, then we cannot do it. We'll do some other alternatives. Here we have stress testing. Okay, it's normal ECG, but when we do an exercise ECG, there is ST depression that appears. So there is some sort of ischemia happening. This is angina. So what should we do after that? If the exercise stress ECG is positive, we have to do coronary angiography, but the patient refuses it because it's invasive. Since he's refusing coronary angiography, which is the preceding procedure before going into angioplasty or any other form of revascularization, we cannot do the revascularization since the patient is already refusing the invasive measures. So we give him the medical therapy. What are the medical therapy of angina? Like, what other things we can do? What are the things that we can give other than revascularization? There are a lot of options, but the first line is the beta blockers, and we have non-dihydropyridines, calcium channel blockers like verapamil and diltiazem. Dihydropyridines, calcium channel blockers, are also used, like amlodipine and other things. Nitrates is prescribed in the case, sublingual nitrates when needed, and ranolazine is only given in refractory cases. So basically, beta blockers and nitrates, which are prescribed. The question is asking about the mechanism of action of each one. This is the take-home point. And the beta blockers and non-dihydropyridine calcium channel blockers decrease contractility and heart rate. They reduce the heart rate. They decrease the contractility and heart rate. So beta blockers are given as a first line. If it's contraindicated or patient need to change it, then you can give non-dihydropyridine. This is the usage of non-dihydropyridine as it's there in the explanation of the UWORLD already. Nitrates act by preload reduction. It's given as needed, sublingual nitroglycerin when the attack comes. This is the major way it happens, and it's asked many times in other questions. Coronary vasodilation after load reduction happens with dihydropyridine calcium channel blockers, and ranolazine. They inhibit the sodium-calcium exchange. This affects the contractility and stuff, but this is all just reserved for the refractory cases. That's it for this question, and thank you for listening. If you have any question, do not hesitate to keep it in the comment section, and good luck.